Slap lesion. A slap lesion, superior labrum anterior to posterior, is an injury to the top part of the labrum in the shoulder joint. The labrum is a cartilage structure that surrounds the glenoid cavity of the scapula. This injury usually happens because of a trauma or repetitive high demand movements of the shoulder, such as throwing sports or jobs that require constant arm lifting. Movements that cause the lesion: abduction, flexion, and external rotation put stress on the labrum by pulling and twisting it. These forces can compress the labrum and worsen the slap lesion. Structure involved in their biomechanics. The superior labrum and glenoid cavity. The labrum increases the depth and surface of the glenoid cavity. This makes the shoulder and joint more stable, helping the humeral head stay in place. The glenoid is concave, allowing the convex humeral head to glide smoothly. Convex-concave rule. When a fixed concave surface, here the glenoid, interacts with a moving convex surface, humerus, the sliding direction is opposite to the bone's movement. A more convex humeral head improves load distribution and stability. A deeper, more concave glenoid makes the joint safer. In the shoulder, there is less joint congruence, which allows for more movement but also increases the risk of instability. Abduction, and convex rule. During abduction after 60 degrees, the humeral head may press against the superior labrum, causing a block. If the labrum degenerates, the concavity is lost, leading to instability. External rotation during abduction can increase stress on the superior labrum. This repeated movement with added weight can wear out the fibrocartilage, worsening the lesion. Now we're gonna see the ligaments in the capsule. Glenohumeral ligaments, middle and inferior. These originate from superior labrum and attach to the anterior neck of the humerus. They limit abduction and contribute to shoulder stability. They tighten in the front during abduction while the posterior capsule relaxes. Then we have coracohumeral ligaments. Stabilize the humeral head by attaching to the lesser tubercle trochin of the humerus. Originates from the same place as the short head of the biceps and on the coracoid process. Posterior capsule. Essential for stability. It prevents anterior dislocation and compensates for weakened anterior structure. And now we have the glenoid ligaments. Role of the biceps tendon. So we have the scapula with the coracoid process, and with the short heads of the biceps. But now we're gonna be focused on the long head of the biceps tendon, attached to the superior labrum. Strong biceps contraction can pull on the labrum, causing compression and degeneration. We can see it here clearly. The two heads, one is attached to the coracoid process and the other on the superior labrum. So, this leads to pain and worsen the slap lesion. Indeed, rotator cuff muscles have big role in the slap lesion. So now we're gonna focus on one of the muscle of the rotator cuff is the supraspinatus. attached to the greater tubercle, and it helps with abduction. It also resists gravitational forces and external loads. We have the infraspinatus rotates the greater tubercle upward and inward during abduction. Both muscles stabilize the humeral head, and injuries to these tendons affect the movement of the greater tubercle and the labrum. Impact of repeated abduction with loads. To finish with, we have the scapula-thoracic joint, which is a false joint. The scapula moves thanks to surrounding muscles. This is called the scapular rhythm. Proper scapular mobility and stability are critical for shoulder biomechanics. If scapular mechanics are altered, shoulder stability decreases, worsening the slap lesion. Clinical signs. Patient with slap lesion will have pain, reduced stability, difficulty in lifting the arm above 60 degrees.